we're collecting names through the chat box, partly because we need to keep attendance for CME purposes. We will send everyone who participates live a certificate of participation for each and every webinar that you join live. And it is also important for those collecting CME credits to sign in and put CME so that we can document that and make sure that you get your 3 main Pro Plus credits for this. And it helps us to keep track of who's joining. We're gonna, oh, I have 1201. So, and for those who are joining by phone, if you're not able to text while you're driving or on the chat box, just email the facilitator or myself and let us know you joined by phone live or and with your number or your name, and we can connect those things. Okay, I have 1201. We're going to start. Welcome to the first session of Capacity. As you know, Capacity is a quality improvement project, which you've all signed up for. It is going to help you operationalize what it means to implement early palliative care into your primary care practices. It is funded by CIHR as a research project, and it's 10 sessions with activities along the way. The 2 people who presenting today, which is myself and Mary Lou Kelly, do not have any disclosures, financial, and it is funded by CIHR. This is the team. This whole project has been an accumulation of many years of lots of people's efforts in the communities across Canada to learn how to do this well. And we're bringing it to you in this virtual format in a prospective way. I'm Xian Xiao. There are 17 other co-investigators that have helped put this together, and my 3 amazing facilitators, Maggie, Daryl, and Kayla, who are keeping me organized, who are on the call and monitoring the chat box and keeping all the technology going. We have local mentors who you've probably emailed and met, and we have this network of primary care and palliative care specialists to answer questions on the go all throughout the year. So we have this whole team to support you, but the most important people are yourselves who are signing up to make small changes in your practice that will add up to a big change. So Happy New Year, everyone, and we're gonna get started. Session 1, it's 10 steps. We're at step 1. Many people think step 1 is, identify, but really we've learned over time that the most important thing is build a strong team. And each month, except in the summers, we will be moving all the way up till we get to the very top. And I promise you, we have done this in various ways many times, and it works, and we're giving you the best advice, best tips. So that's really the offering here. The session objectives, and these are the same for all of the sessions. Will always be about describing tools and evidence related to the objective. So today's is about building a strong team. What evidence and tools do we have to do that? Are there tips, strategies, and practices so that I can operationalize that into my practice? And we will always end with a 30-day challenge or an activity to help you apply this to your work right now so that you can, in the tomorrow, do something different, okay? So those are the objectives typically follow this format, and today's objective 1 is all about building a strong team. We also always want to start what's in it. It says what's in it for me, but it's really what's in it for you. What we've learned over time, and this will be reiterated, I'm sure, is when people start, if they don't focus on who's at the table and who are the relationships that we're building and strengthening, it all falls apart when that person leaves, when the funding ends, or when a little bit of pressure comes. What we've also found is when people have a strong team, and that's the secret to doing this work. Palliative care is a team sport. And if we do it well, people find they have more collaboration, they get more job satisfaction. There is, finances involved in this, but they have more time to do it. They have less burnout. So these are all the benefits of doing good palliative care in their work, but also making sure that they focus on the strong roots of their team. So to start things off, and the sessions will all sort of follow this format, we have a reflection question. So this first session's reflection question, I'll take a minute here to encourage you to use the chat box. But what are some barriers or some fears you might have when people talk about implementing a palliative care approach in your team? So you've signed up to do this because this is something you've wanted to do, but clearly this is not an easy thing to do. So what would you say, either individually or as a team, the number one or two biggest barriers? And I'll invite Maggie, one of the facilitators here, to just monitor the chat box.
So Elliot Lake, you can just type in your response to the chat box, but how do we access audio via phone? Okay, I will, we can copy and paste the phone number into the chat pod right now. Daryl, can you do that? So some of the responses we're getting right now is coordinating the work. Thank you, David. Time, yes. Not all the team members may be on board. Good. Experience, understanding of what palliative care is. Yes, excellent. Increased workload, time, fear of time once the floodgates open. Yes, I like that. Difficult conversation, various roles, scheduling, large roster size. Wow, lots of barriers here, Cian.
Okay, fantastic. Okay, so we are going to address some of these today, and in the 10 steps, we will get to things like the roster, conversations, etc. So that's why we've broken it up into 10 steps. And it's perfect to start in the new year because you're getting these emails of like exercise and have a great 2020. So we're essentially trying to break it down into manageable things that you can focus on. So by the end of the 10 steps, you'll have done the complete package, as opposed to just sitting all in one day and having 40 things to do when you end up being overwhelmed and don't do any of them. So really the whole program is designed to break it up into one idea, one concept that you can focus on, and it will build on itself. Okay, so we've heard many of these barriers over the years, the scheduling, the right people, what is palliative care and this misunderstanding of what it is, the lack of organizational support. People don't value the work. Okay, we're going to address these in this project. I'm going to jump right into the meat and our main offering. So every session will have 2 speakers. I happen to be the first one. And what we've basically done, it's all those 17 co-investigators from across the country. We've asked them to reflect on their many, many years of experience doing, building palliative care capacity in themselves and in other teams and primary care teams, and to summarize their best learnings in about 15, 20 minutes. So that's the value to you. They sort of have these very short TED Talks, so to speak, of their best experience and advice for you. And we've grouped them into those 10 steps. And as a listener, we're hoping that there will be a light bulb moment or some nuggets that you can say that resonates with us, and we can take that away and we can apply that to the 30-day challenge right away. Okay, so I'm going to turn it over to Kayla to kick us off with what are some of the most important things I've learned over my time about building a strong team. Thirty-second bio. I'm a Canada Research Chair in Palliative Care from McMaster University. I've been doing research in models of palliative care delivery for over 15 years in the US and Canada and in Ontario. And I spent a lot of my career using large databases, looking at the effectiveness of palliative care, particularly in the community. So home care, primary care providers, and how they impact end-of-life care outcomes. But I'm at a stage of my career where I feel like the burning question isn't whether palliative care is effective, but rather how do we do it? We know that most of the palliative care models are specialist-led, but there aren't enough specialists to do the work. So this work, my talk, the entire capacity intervention is about supporting primary care providers and teams to do a palliative care approach and to support them to make change on the ground. And that's what this intervention is about. And this is why I'm really excited to spend the next 15 minutes or so telling you what I've learned of how do you start. So I was asked 2 questions. What is the evidence, tools, and resources that come to mind when starting to implement a palliative care approach? And what strategies, lessons, and practical advice do I have to offer to build a strong foundation in a team? Let me give you a very 1-minute overview, a brief overview of where the evidence base is coming from. Capacity is an intervention that was adapted and tested looking at other models that have already happened. So the basis of this is the gold standards framework, which started in the UK in 2003. So for over 15 years, they have been helping primary care teams, long-term care homes, hospitals implement a palliative care approach into their practices. And since in all that time, they have also had various versions brought over to British Columbia, who has done quite a bit for several years. Nova Scotia has started doing things. Australia has worked on doing this in primary care. So we have looked at all their materials and their adaptations and pulled them into Capacity. We've also built on the decades of work from Mary Lou Kelly, who is a national treasure, and she's the speaker right after me. And she has done work on building primary care capacity to do palliative care in rural communities, in First Nations communities, on long-term care facilities prospectively. And she's done them in various pilot projects, small groups, and we are now scaling this up to you and using this virtual format. And we're also building on the research evidence of research that I have done, where I've looked at the effectiveness of teams all across Ontario and proved that they're effective and how different they are, but they're all equally effective or differently effective, but trying to understand what it is that they do that makes them work, which makes them sustain and scale. And we put a lot of that work into a change guide called the palliativecareinnovation.com, which is where these webinars will be posted when they're finished. Okay, so that's a lot of the evidence it's going to build on. And the very first lesson that we learned, especially when you start, is to be really clear what we're talking about when we say palliative care. We are talking about a palliative care approach, and we do not mean end-of-life identification. Because unfortunately, by the time you're at end of life, it's too late. You're already drowning. There's not as much time to really intervene and be proactive and go upstream. Of course, people at end of life can benefit from palliative care services, but a palliative care approach can be used earlier on. And so that's why we talk about this approach of care that can be used earlier, and it's this early identification. So we want to find these people before they're, maybe when they're knee deep in water, as opposed to already with just their fingertips showing. So this whole work is about, yes, it's about understanding what to do at end of life, but what can I do earlier upstream? And that's philosophically critical to understand when you're first starting. Second, the second most important thing we learned when people get started is, what is the impetus for a change? People started often when it was top down because the goal was to reduce ED visits and hospitalizations. And what we learned is that if you start from that is a recipe for failure. What we realized when we talked to teams that were successful and were able to stand the test of time and didn't, collapse when grant funding ended or their nurse, got moved, is they were focused on doing things that improved the patient and family experience. And we took all the things that they said they were doing that helped, and we put them into these 7 quality commitments, which you're free to use. And, maybe this is the beginnings of a vision statement for your team, or even just some of the things that you're trying to work towards. But there are things like, number 2 is we will communicate and connect as providers so you don't have to repeat your story numerous times. And number 5 is we will provide education and guidance so you can prepare for what lies ahead. We will attend proactively to the wellness of your mind, body, and soul so all forms of suffering can be alleviated. So these were the things that they were working toward very tangibly as a team. They weren't first and foremost thinking about hospitalizations and ED visits. They were first and foremost thinking about how can we communicate? How can we respond in a timely way? What education advice are we giving to the patients and families? So this is the core of a successful team, to have a common vision. And the other take home is these weren't just benefits for the patients and families. So never feeling alone, not having to repeat your story, feeling prepared for what lies ahead. These were benefits for the providers as well. So patients, families, and providers also benefited when they worked together, and we did this right. So keeping in mind what is the goal, focusing on the right things to do for patients, families as best we can in little steps was what was going to get you there. Don't worry about the big dot measures or what report so-and-so is asking you for. Focus on what you're doing at the bedside, which is why you probably got into medicine in the first place. Third thing that we really learned is we get asked all the time, what is the best model of care? And what they're really asking is, what does the research evidence, the randomized trials show worked in such location? And they want to replicate exactly that model, all across everywhere. But we all know that doesn't work, because what we've learned is every community is unique, and the ones that succeed build on the local resources and strengths of that unique community. So the right question is, what works best in each community? And what strengths do we have as a local team that we need to build on so that we can provide this care? I wanted to show this visual here about the different models of care, because I want to again emphasize that we are not trying to promote this substitution or total transfer of care model where the primary care providers sort of give up control to a specialist team and could take over the care of the patient, because some people misunderstand our intervention to be like, we'll identify the patients earlier and refer them to a team sooner. That's not what we're trying to do here. We're trying to go onto the far left, where we're focusing on this consultation model where we can try and support primary care providers to manage the care of the patient as much as possible and bring in a palliative care specialist as needed. And in some ways, they're really a consult less to the patient and more to the physician team or the provider team or the nurse-led team. And they're really, the specialist acts as a best supporting actor, and the primary care team really remains the feature star here. So the key here is about clarifying the model. Teams, what we learned in all our research is teams can work across the different models that we saw there. There is no best model, and we're focused on we can build primary care-led models. And we need to remember they're not defined by the size or where they're housed or how they're funded or the composition of the team. We found different combinations worked equally well or could be effective. There was no cookie cutter approach, and a locally relevant model worked best. So really the take home is every region can and must have a unique model that works for them. But one thing that I do want to say is the teams that were successful had a really clear idea of their own team, but also the external partners and the broader services in the community. So if you only focus on the people in your room right now, you won't succeed because you need the other people outside of that room. But if you only focus on all the system things, you will not also, you also don't succeed because you need to build something different with the people around you in the room. So there was this, understanding of how they fit into the bigger picture, but knowing that they could take the lead of change. Okay? I'm more than halfway through, so stay with me. So what number 4 is what we learned is what makes teams effective. And we get asked all the time about what were the best tools and processes that they used. And we naively thought that we would put them onto a website, put all the best tools onto a website, and people would magically go to the website and everything would be solved. And we all know there's examples that does not work. What we learned is those tools and processes were facilitators for building a strong team. So the right question is, what is needed to build a strong team? And we did know palliative care is definitely a team sport. So it's not just about the tools, which is the head, the knowledge, but it was also about the hands and the heart. It was about the philosophical change in your heart, and then the hands piece is operational strategies, practical tips to make it easier to do the right thing. And you needed all three. So it's not about the tools. And the best example of how we can change the heart and the mind is that where people start is they think, this is Mary Lou Kelly's, tree framework, which I use very often, and she's the next speaker, and she'll add some color to this. But people think they start at step 4. Let's focus on starting on create the program. And this tree model really shows that you need to have strong roots and a strong foundation and antecedent conditions, or else this tree will topple over. So building a strong foundation is about investing in the members of your team that are going to help do something different. And then the other pieces will happen. And this is a framework from our change guide, that the keys to building a strong team were about trust, communication, having mutual respect, and this flat hierarchy, so that everybody in your team was equally respected and had a role in achieving your goals. And change happens at the speed of trust. So a lot of the 30-day challenge this week is about what you can do to take some beginning steps to enhance the trust you already have. We also found that they were flexible and adaptable, had a sort of this entrepreneurial spirit, and had a clear sense of their purpose. So these were just some of the factors, this PEP framework, that was key. And lastly, when people start, the most common thing I hear is, well, we can't boil the ocean, which is another way of saying this is a lot and maybe we are overwhelmed. It's overwhelming. There's too much. And what I try to say is, yes, you can't boil the ocean. That's not what we're trying to do. We're trying to boil a pot of water. We're trying to take things step by step, and it can be done. And we start with small steps, and it makes it easier to go bigger and bigger. And the journey is winding, but as long as you keep putting one foot in the other, you'll be making progress. So our promise in Capacity is that this no NASA rule, that it's not rocket science, it's simple, practical advice and tips that we hope you can take away, little nuggets that you can practically use in the next 30 days. And really what we're talking about is an extension of what you are already trained to do. These are skills you probably already have and just never thought to apply them in this way, or needed a little push. And this is what we hope Capacity will do. So to answer the second question, what are the practical tips that we've learned, particularly at this stage of building a strong team? Here are my top tips for you, okay? Strengthening relationships requires an intentional building of trust. And these are super simple things, but I'm telling you, they've worked even outside of palliative care. Have a coffee date with people, have a lunch date with people, or a drink. Being able to see them face to face, even if there are differences or historical baggage, finding common ground of what are we trying to achieve, and seeing, understanding a different side of person besides work allows you to have this personal connection that can help you move forward. And the other key person in this relationship is your office administrator, the gatekeeper person. That's critical to this effort because they play such a key role in all the different aspects of making things move. I often hear these people are the people who says, I do whatever it takes to get things done. That's who I'm talking about, where you need to bring that person on board. Home visits are a key part of success in providing home-based palliative care. But when we say that, people misconstrue that to mean, well, it means the clinician, physician or nurse is supposed to do all the home visits and we're supposed to do them 24/7. No, that is not what we're saying. No team did that. Okay? No team started like that. It's about understanding, appreciating what a home visit, what information you can get from a home visit, whether you do it yourself or a home care nurse that you can have regular communication with, is telling you. They're the eyes and the ears. And then figuring out a way to have clear expectations of what we're doing during office hours, after office hours, and eventually people get up to a plan for 24/7. And sometimes the plan is from 10 to 8 in the morning, you call this number or you call 911. But we have all these things in place so you don't have to call 911. But no one person is on call 24/7, 365 days. Okay. Formal and informal communication methods were critical. So people told us they had group huddles or biweekly rounds, and they had group chats or texts and emails. These very simple things were ways that they were able to communicate about patients in rapid real time. They did not have EMRs that were all magically connected. And the most majorly underused technological advancement was the telephone. When you're not sure, just call someone. Don't send this long email or text or write a note. They just called them or texted them. The new calling is texting, right? To say, what do I do here? Or this is what I'm noticing. Let's bring this up. And I think I've heard from tips from people that says, what's the most important thing I need to know about this patient? Like I need to know, once a week or something. Okay, and the last tip was about individual motivation. It all starts with believing that you have the power to change yourself, which we can change an outcome. And it does take time. There is an evolution, but it can be done. We see it all the time in teams. It started with one person who then helped other people to see, and very little changes made a big difference. They added up into a big philosophical and practice change. And I want to end with this. I always end up, you'll end up pointing to system barriers, and we don't have enough support and money and people, and all those might be true. But every time you're pointing and naming and blaming something, there's 4 fingers pointing back at yourself of what is it that I can do in this moment today that could lead to support a change in that. So my take-home messages are these. Palliative care is a team sport. You need to intentionally build a strong team and build trust in your team. It is not about knowledge and tools. We are going to try and provide you the evidence and the tools, show you the best tools, but ultimately it's about hands, head, and heart working together. And we're going to emphasize building the practical tips and go the practical nuggets that you can take away and use right away. And ultimately, this whole thing is predicated on the belief that each team member has a role in enabling change and that change can happen. And we see it all the time. And this whole intervention is built around that. Thank you. Okay, so I'm coming back here. It's weird listening to yourself. Okay, so hopefully that was helpful in some ways. It does address some of the barriers that people talked about different people having different understandings about what is palliative care. How do I involve the people that are required to build a strong team? How do I get their buy-in and things like that? So some of those will be addressed in the activities, and some of the other things we'll address in later stages. But what I want to do right now is jump to the second video. Hopefully, as I'm talking here, you can take a minute or 30 seconds to just think about, hopefully there was an idea or two in there about where you thought you were going to start and where we're actually hoping that you focus on the relationships and the trust of the people around you. What are their motivations? What's our common vision? When we say palliative care, are we all working towards the same thing? That's critical at this step. And to emphasize that, we invited another speaker who represents primary care. Most of the time it's a peer of yours, someone who works on the ground, to discuss what are their practical tips about building a strong team. And our first speaker happens to be, our second, excuse me, Mary Lou Kelly, who I mentioned a few times. And so now I'm going to queue up to her video, and I will connect us back at the end to recap and send you into the activity. Okay, so Kayla, if you can help me put up the video, that'd be awesome.
Good morning. My name is Mary Lou Kelly, and I'm speaking to you today from Thunder Bay, Ontario, from Lakehead University. Happy to be here. My work is from the social and community perspective. I work closely with healthcare providers in rural communities, long-term care homes, and First Nations communities over the past 35 years. And for the next little while, I'll share some of my experience and learnings with you. I've been asked to start by giving a perspective on some of the barriers that primary care teams face when taking on doing more palliative care, and also some of the strategies or tips that I've learned in how these teams that I've worked with have overcome them. There are four things that I'm going to talk about just briefly. The first one, which is pretty common, is that teams feel overwhelmed. Everybody in healthcare is working as fast as they can, doing as much as they can, and I believe they're often already feeling a lack of organizational support. So the first reaction I often hear is a sense of resistance, not because of lack of the importance of palliative care, but just, are you kidding me? That's one more thing to do. As I work with teams over the years and frontline healthcare providers, I think I've learned that one of the solutions is for them to realize that they are already doing most of what it is that they need to do to provide excellent palliative care. It's, in many, many ways, just good quality care that people are already doing and being expected to do. What's different is getting a little bit organized about it and a little bit more systematic. I sometimes have providers think about, when we were providing palliative care to this particular client, things went extremely well. And then think a little bit about, well, what were the elements that made it go so smoothly? What were the value added? And those are the kind of things really this whole capacity project aims to try and highlight. But highlighting them and then trying to be a little bit more systematic. And at the end of the day, it turns out actually to be less work. And I'll just give you a brief example. I was working with a First Nation community, and they had worked very hard to try and better organize their home care program, their local home care program, to provide palliative care to people who wanted to stay home till the end of their life. And we did a lot of things. We educated the providers, we got better assessment tools, better teamwork amongst the various home care aides and nurses and the visiting physician. But the last thing they wanted to do was get the nurse, who wasn't in the community all the time, a cell phone. So she could be on call evenings and weekends in case some kind of crisis rose, because there wasn't somebody locally that could respond to that. And we did this, and in 6 months, I said to the nurse, how many calls did you get from the community? And there were probably about 6 clients receiving care on the palliative care program. I said, how many calls did you get? None, she said. And I was a bit surprised by that. And I said, well, what do you think that means you don't need the cell phone? And she said, absolutely not. I very much need it because they need to know I have it. But since we've created our palliative care program and we're much more organized and proactive, doing our home visits, identifying things that might come up, educating the family, having a really clear care plan that everybody knows, we actually aren't having any crises. So that's an example where they started out feeling overwhelmed, but they really were doing almost everything that they needed to do. And it just actually went more smoothly and became a lot less work for everybody. And there were very few crises when they became more systematic and planful and organized. So that was the first barrier I wanted to talk about, feeling overwhelmed. The second one is reframing the meaning of palliative care or the palliative approach to care for yourself and others as an added level of care. This is not generally how the general public and sadly how many healthcare providers think about the palliative approach to care as an added level of care. They immediately focus on what is not going to be done. Hope will be removed, access to treatment and interventions will be removed. And there's a real focus on that. But we in the field know that palliative care is really about focusing on what each of the members of the healthcare team can do to add to the quality of care on a day-to-day basis. Yes, the context of the whole thing is the person is in the last stages of life, and because 100% of people die, there's a lot of things that we can't really change. But if the emphasis and the focus of your care and your conversations is what we can offer in the way of quality pain and symptom management, psychosocial, spiritual support, really focus on the things that can really make a difference in a day-to-day basis. I'll give you another example, and this one comes from my personal life. Someone that I know, her husband is got cancer and is in the last year of life, and he was feeling very discouraged and distraught, and she was feeling extremely helpless about what she could do. And so we sat down and talked about how his day-to-day life could be more meaningful and enjoyable to him, so he would have a reason to get up in the morning, and how she could be doing things that made it feel like she was really able to contribute something positive. And this sounds like a simple thing, but she approached a very select number, 2 or 3 people that he really, really enjoyed visiting with, and she called them and made a schedule, and they came over at a time of day which was the best part of his day. He enjoyed the visits, gave him a reason to get dressed, and the family member, the one that I had talked to, said, I don't feel as helpless anymore. I have a plan. I feel that there's something I can do. So that, as a social worker, which is my discipline, would be the kind of thing that I would be focusing on with clients, trying to take the emphasis away from the dying and focus on what you can do on a day-to-day basis to make living better. So that's the second one, reframing the meaning of palliative care. This is an interesting story that came out of long-term care and speaks to reframing the meaning of palliative care. But I had asked the manager, how many deaths do you normally have in this long-term care home in a year? And she said, well, about 30. And I said, okay, we talked a lot about the surprise question. Would you be surprised if this person died in the next year? And some of the tools that you can think about use to help screen or identify people who might be at risk of dying in the next year. Anyway, so off she went, the manager and the director of care, and came back and gave me a list with 5 people on it. And I said, oh, I'm a little bit surprised because you said you normally have 30 deaths a year, and now you've given me a list with 5 people on it. And she said, Mary Lou, I just couldn't write people's name on that list because I felt like an executioner. And that was really such a learning for me, that it was still the negative idea of palliative care is only about dying, and it's not about the things that we can do to improve your quality of life on a day-to-day basis going forward. And it took quite a long time to overcome people's perceptions that instituting a palliative approach to care was a death sentence. The third one that I hear from providers in most of the settings I've worked in, which is rural communities, First Nations communities, long-term care homes, they really worry about the lack of social support and the sense of social isolation that they often find themselves in, and making decisions or providing care, often when they're on their own in a home or working a shift in long-term care, and there are only a very few people there. And so what I think the solution there is to spend an awful lot of time on an ongoing basis just building the relationships within your team. I went and visited a really excellent rural palliative care team a number of years ago, And I asked one of the providers, what was the secret to success of your team? And this provider said to me, I never feel like I'm alone out there. I'm in the home and I'm making the visit, but I feel absolutely confident that if I need to call another nurse, if I need to call a physician, if I need to call the pharmacist, they will be there and they will answer my questions and they will support me. And these, of course, are all of Sien Sao's PEP framework, the things that make a really effective team: trust, communication. But I can't stress that in my own work, having those operationally in a team make a big difference in solving that ongoing fear that people feel socially isolated and are really anxious about the responsibility of providing palliative care in the community. And the last one is communication, having conversations with families and other healthcare providers on topics of death, loss, and grief. As a society, we are not good at it. And as healthcare providers, we're actually not that good at it either. Whenever I have done surveys of healthcare providers about their learning needs or spoken in conferences to healthcare providers about issues that they experience, inevitably, one of the things is we really have a hard time talking to people about these issues of death, dying, loss, and grief. When they have questions about spirituality, when they become very emotional about things, we really have, we really struggle with that. And sadly, then they often avoid it. And I've had family members say to me, I really want to talk to the healthcare providers about what I can see happening with my loved ones, but nobody will talk to me. The PSW tells me to talk to the nurse, and the nurse tells me to talk to the doctor. And I just feel like people are really avoiding the whole ability and willingness to talk to me because they're uncomfortable. So I think we've got to get over that. And one of the things I think works best is simply practice. And I think having this trusting team I talked about earlier, where you feel really safe with one another and doing really good debriefs after you've done a job of palliative care, whether you've been really satisfied with the outcomes or not, do a really good debrief and find people that are really good at having these conversations and shadow them for a while. Go to a hospice unit and do some shadowing. You've got mentors in this program, this capacity program. Just shadow them and listen to the words that they use. And I think you'll find that it's not as challenging as you think you would find it, and that people are just so appreciative of the effort being made to reach out and try and empathize with their situation, answer their questions, and give them some assurance about things that are normal that they're experiencing. The other thing I've learned, and this is not just with staff, although to some extent it applies to staff, but with clients and families. I'm working a lot in the community now with compassionate communities. And I've decided that one of the reasons that people are resistant to advanced care planning is they don't like the idea of planning for death. So I now talk about preparing for the future and preparing for the inevitability of needing more care, and preparing so family and loved ones know what your wishes are. And I found the word preparing works an awful lot more than the word planning. So that's just a thought. But we prepare for our social roles. We prepare to get married. We prepare to have a baby. And we need to prepare for our end of life. So how can we implement some of these things into practice? Some of the things that Dr. Xiao has talked about from the evidence, and even some of the things I just shared with you about barriers and solutions. I think, first of all, think about your team. This is not a time to be a lone ranger. And your team has a number of levels on it. Your team has to, broadly speaking, in primary care, include the family, because the family provides almost 90% of the day-to-day interaction of the person who is being cared for in the home. And then you have to think about the immediate clinical team that you work with all the time. Most often it's a physician, a nurse, a psychosocial person. And then there's that next level of person that is really, really instrumental in the community, people that may be coming into the home to support the family from the neighborhood, from friends, from other social agencies. So I think really thinking about the team broadly and wanting to be inclusive about all the circles of care, right from the family, right through to the neighbors and friends, and proactively getting them involved and helping them think about what they can do is really, really valuable. The second thing is, consistent with that, is I believe it works best kind of bottom up and inside out. So what doesn't work very well is swooping in from outside of the family or community or situation you're in and providing a lot of advice from the top down. And I know that there's a lot of policies and procedures and best practices that everybody is trying to adhere to. And I get that, but what I'm trying to say is when you are entering a situation, you have to really generate some of the strategies and solutions from the bottom up and from the inside out, saying to family and patients, you know, what do you think would work best in this situation? What would help you? How could we help you? What kind of supports do you need? And really building that circle of care slowly from the bottom up and from the inside out. And you as the external healthcare provider have an essential role to play in that, but you are really needing to fit in to what the broader social and community system can provide, because you can't be there all the time. And then really just thinking about what I said earlier, that the palliative approach to care is very much a philosophy and a new approach to thinking about people with advanced illness in the last year of life. And it's not completely different from what we do on our day-to-day basis, providing quality care, just a little bit different way to think about it. So how do you know who the key people are? And I've made general reference to the fact that they can include family, frontline health care providers. But I think the way to do it, looking at it from the bottom up, is who are the key people who need to be on the train or the train is not leaving the station. And I'll use the example of a lot of my work in long-term care. The managers of the long-term care home were really committed to enhancing the palliative approach to care in their home and formalizing the program. The nurses were keen to do more work. The home physician was keen. But I asked the question, who is at the bedside and who is doing most of the care, 90% of the care on a day-to-day basis? And it was the personal support workers, the frontline workers who were doing that care and really creating that day-to-day culture of living. And so I said, well, we've got to get the personal support workers on board or the train simply will not leave the station. And so we began, and that was sort of the bottom-up recognition of bringing them to the table and really recognizing what their role was, how they could be supported, what their learning needs were, and then how could they become a meaningful part of our team. And again, don't forget the gatekeepers. It's very critical. My mother lives in an assisted living for seniors building, and there are many people in that building who are very frail and are experiencing some dementia. And the young woman that mans the desk in the lobby greets them when they come down, pays attention to the visitors as they come and go. That individual is essential and somebody that you would want to engage if you were caring for somebody in that building with the palliative approach to care, because that person is going to tell you on a day-to-day basis what kind of issues and changes you need. So just think about who is going to be the most important and matter as you move forward. Another thing I learned in long-term care, and it'll apply to community care as well, but it's this whole issue of what's in it for me. So let me go back to what I just said about the personal support workers and the train not leaving the station. And when we first talked to the personal support workers about our interest in developing the palliative care program in long-term care, I would have to say that they were very, very skeptical and they were very angry. And their immediate response was one of the barriers I mentioned earlier. We're already too busy, we're overworked, and we're under-resourced. And now on top of everything else you want us to do, want us to do long-term care. And so I sat down with them and I said, so the first thing I would say is I learned from the bottom up that the world of the personal support worker is all about the caring relationships they form with the residents and the families. That's what gets them to work every day, and that's what they get a sense of personal satisfaction from. And they take great pride in their relationships with the residents. So I said, what do you struggle with when the person is dying? And so they said to me, Mary Lou, what we struggle with is sitting at the bedside of the residents in the resident's room, and the family is sitting vigil at the bedside. The resident is dying, the family's distressed, and we don't know what to say and what to do. We feel helpless. And I said, okay, if that's what would make your job better and more satisfying, let's work on that. What can we do to help you feel more confident about what you can do and feel like you can make a meaningful contribution? Anyway, we had lots of conversations over time, but what came up was they prepared a comfort care bag, but the comfort care bag is basically a gift bag from the dollar store full of information that helps and educates and supports family about what to expect, why is their loved one not eating, and some really personal things like poems, or one of the staff knit crochet angels and put them in there. And so they could go to the bedside and they could offer this comfort care bag as a symbol of their caring and their support. They could talk about the contents of the comfort care bag, and it gave them something to do. So the next point really is we reframed this whole issue around formalizing and developing palliative care as something that would make their job easier, better, increase their job satisfaction, increase their collaboration with the nurses. They felt more respected, more appreciated. In fact, we sat down with them and developed a set of competencies for the work of the PSW in palliative care, because of all the healthcare professionals, doctors, nurses, social workers, they were the only ones that had no articulated competencies. And it did make the organization feel like they had nothing to offer in the team, which is so far from the truth. So we can't think of palliative care as something just to do off the side of the desk. You're supporting what people are already doing. And it's not rocket science. It's what good quality care looks like already, but we need to do it in a more organized and systematic way. So I'll go quickly over this. I already mentioned that to me, it's a bottom-up and inside-out business. If you're working in the team, if you're working in the community, if you're working in a long-term care home, coming in from the outside and providing all kinds of expectations, it is not the way. You need to work with the frontline workers and in the community, with the family, and really build the care team and the care plan up from what people can do. And then you need to sort of bring everyone along with you as you move along the trajectory of the person's illness and form the relationships that will help you do that as you go along. Back to the whole idea of getting started, what will kind of get that change process going, and finding that thing that people can begin with so that they start to develop some momentum. And in the example that I used about the personal support workers, that catalyst for change was that comfort care bag. I mean, as I said, the comfort care bag was just a dollar store bag with a bunch of stuff in it. But that isn't really what it was in the change process, because it was the thing that symbolized for them that this program was going to make their own work better and more meaningful. It was going to help them support the residents and the families better. And it empowered them to think that they had an important role to play. And it just really changed the dynamics. So in the situations you're walking into, it might not be a comfort care bag, but there will be something. In the other example I gave about my friend who was feeling helpless when her husband was at the end stages of life. I mean, she got busy and made a list and engaged people to visit on a schedule that she had control. And that was the thing that was the catalyst for her. It was a symbol. So these things are a way of getting buy-in from other people, and it gets back to what's in it for me, and how can they be brought to the table and participate in a way that not only makes palliative care better, but makes their own situation more meaningful and satisfying. So take-home messages, identify in the change process who the train cannot leave without, who are the people you have to get on board. That's going to take you to what's in it for me, because there is something in it for everybody. The worker bees and the frontline people have to buy in, find that thing that will really be a catalyst for their engagement and get them feeling empowered to do the change and make the difference. Palliative care is not taking things away. It's adding to the care people are already getting.
Okay, I'm gonna bring myself back to share the screen. Okay, so thanks for bearing with us, sticking through the two videos. If you had, just to remind you that the whole recording will be posted on our website, palliativecareinnovation.com, where you can watch the whole thing. There are also the two videos that are posted on YouTube, so you can also just watch those individually. I think the take home from both Mary Lou and I was that you need to focus on the team. And I think Mary Lou did a beautiful job telling these stories about, feeling like an executioner and the comfort care bag, and, much better job than I did, frankly, to address some of those barriers that came up about, how do I find time to organize people? How do I bring the people together? How do we have the same definitions? So all of that is well worth effort to figure out, who would the train not leave without, and to get them on board and to come together for a common vision and purpose. So now we're going to move from the tips and strategies and do some quick activities to apply this to your work. And I'm looking at the time and we're doing okay, but I just want to remind you, typically we have one 30-day challenge. Today we have one very short 10-minute activity and then, your 30-day challenge. I'm going to give you the instructions to those. And then I will let you go off to figure out the time to do that, whether it's right after or, a planned meeting later in the week. The 10-minute challenge, okay, is really about what I talked about, is that clarity about who is the inner team, who are the core worker bees, and then who's the broader team, and understanding the interplay between that. There is an email that all the team leads got with a 1-page this morning. This is the idea of the inner team and the broader team. And then I just clarified the inner team might be more than, the QI study team. The capacity QI study team are the people who filled out all the baseline measures, who are probably in the room with you or who you're going to meet with regularly over the course of this year. But there might be other people who can't attend lunchtime webinars, but are really critical that if somebody needs a palliative care approach, 90% of the time, this person's going to be involved somehow. That's your inner team. And then the broader team is depending on the needs of that patient. These people may or may not be involved. So hospice coordinator may or may not be involved depending on the preference of the patient, or the pharmacist who delivers drugs to the home may or may not be involved depending on the complex symptoms, etc. Okay, so differentiating the two. So the activity is very simple. It's a team network analysis. It just asks you to list, to think about who are the people on my inner team, who are the people on the broader team. Because we want you to send this to us sometime, after this call or this week. You don't have to put their full names, you can just put their initials, but we really want you to think about how often you interact with them now and your level of trust with them. And I think this connects, particularly the inner team part, this connects to Mary Lou's comment about who will the train not leave without. If you're missing critical people on the inner team, you do not pass go. Go and talk to them, have a meeting, but in the next 30 days with that person and bring them in onto what you're doing. Many of you already have your inner team. It's, you have worked together for many years. Some of you are brand new. Okay, so this deliberate description. It's useful for you to really be clear on who do we need at the table to make this work. And then we would like a copy of this because we're going to repeat this at the end to see if some of the trust has increased over time. Okay, so it will take about 10 minutes or, 10, 15 minutes, depending on how big your team is. You could hopefully, if you're in the same room, you can do this right away or at your next meeting. But the 30-day challenge is actually this. It is been used in the NHS and many places across Canada. It's the Sentinel event analysis. We are not collecting this, but it's a very simple questions. Basically, everyone comes together. They think about a case that went particularly well or not so well that they want to talk about with the group. And the 4 questions are: what went well, what didn't go so well, what challenges, what could be improved, and if this were to happen again, what could I do differently? And this is the purpose of this is to allow the key people to share their motivations for why they are doing this and to start the dialogue of who are the key people. It's all relationship based. So understanding that key piece about the people that you're working about, their motivations and why. So this is going to be it's these questions, but you can think about it now. And hopefully in the next 30 days, you can, find a time to be able to have that discussion and just reflect with each other about why you're doing this work and what it means to you and how, what are your common goals. If this Sentinel event analysis tool will be sent immediately after this webinar, along with the evaluation. So those are the 2 activities. One is I'll just show you this network analysis. Hopefully you can send this to us, scan, email, take a picture. And then this discussion tool, just reflecting on a case, talking about, it's not a name and blame thing, exercise. It's this is how I felt when this happened. And it could be a very positive or not so positive experience. Okay. So the next steps between now and the next time we chat in a month is right after this call, you're going to get an email with this Sentinel event analysis question, but also a 5-question evaluation. Everybody in Capacity, there's 192 of us across 35 teams, will all get an email to complete the evaluation. Take you 1 minute. The 30-day challenge is the Sentinel event, the 2 activities, the network and the 30-day challenge. Please complete that. If you have any questions in the next 30 days, email your facilitator, which is Maggie, Daryl, or Kayla. And there is a standing call with the team lead, but sometimes you already know there's an elephant in the room that, that we know about, you didn't talk about it, and we need to figure this out before we can move forward. Email us. We have lots of experience, and we can get the answers to you or start connecting about dealing with those right away. And then sometime very near, day 27 in the next month or so, we will be emailing the team leads basically a broader evaluation about the activity, about were there any practice changes you did, and to reflect on what we could be doing better, but also how what we're talking about can influence your change, or what we can do better to help you support you. So we are going to stay on the line to monitor the chat box to see if there's any questions, but do not forget to sign in. I saw lots of people signing in. If you're joining by phone and can't, text into the chat box, email us after to let us know you joined live, and to put CME brackets if you need that for your 3 main pro credits. And at the end, and all of this whole recording, the slides, and the 2 video links to the YouTube will be posted on Palliative Care Innovation for the whole year, so that you can go back, for members who couldn't join, they can watch it and participate. The slide deck always ends with an appendix, which has the references that we used, other resources that may be helpful to you, that you could look up to if you want to do more reading about it. It links to the Ontario Palliative Care Network Health Service Delivery Framework and shows what part of the framework we're addressing. So in this one, we're looking at how to build a core team, which is the start of the catalyst for everything, and then some other pieces if you're filling out CME credits. So that is the end of our webinar. I think we achieved what we set out to do. We said 2 great speakers giving you their best advice over their 10 years of work into 10, 15, 20 minutes. And we've given you a challenge, an activity that can apply that to your work right now, so that you can help to do things to help you build a stronger team, and think and be very intentional that this is the starting point. So I'm going to say goodbye now. I'm going to turn off my video. The chat box is open in case you have any questions for just until 1:05 or so, and we will keep in touch over the next few weeks. But we will see you again in 30 days on the first Tuesday in February. Thanks, everyone. Good to see you. Happy New Year, and excited that we're doing this together.